Hello, everyone. I'm so excited to have Roger Dowdy, the Vice President of Mental Health Strategy at Providence St. Joseph Health System, join us today. Roger, thanks so much for being here.
Oh, thank you for having me.
So we've talked at length about, behavioral health care continuum. Could you tell us, when you say that phrase, behavioral health continuum, what exactly are you referring to?
Yeah, absolutely. And before I start, I just wanted to say I have no disclosures, and my opinions are my own and not necessarily those of Providence St. Joseph Health System. So now that we have that out of the way. So in general, for behavioral health, we have a very fractured delivery system where the majority of individuals for outpatient care certainly are seen in a private practice, individual private practice community. And as healthcare systems, we've generally had fairly narrow continuums of care focused primarily on acute or chronic care models. And all of these services have been entirely reliant on face-to-face visits. In the context of increasing demand for mental health services, overwhelming, some might say, we really need, in the context of also decreasing capacity, just decreasing supply of providers, we really need to think differently about how we address mental health and substance use disorder concerns beyond how we traditionally have kind of conceptualized and thought about the overall continuum of care.
Mm-hmm. Yeah, absolutely. With that in mind, I guess where does chronic care fit in? How would chronic care models for depression, anxiety, and substance use disorders differ from what's happening today?
Yeah, I mean, there's increasing evidence, and Tom McClellan talked about this years ago, around thinking about addiction and mental health concerns as chronic care conditions, and much like we think about hypertension and diabetes. And so when we think through that lens and use that analogy, it helps to inform us about what that continuum of care should look like, from subacute to mild, to moderate, to acute and chronic. And when we think about those models and we think about again, the analogy of hypertension or diabetes, we think about the importance of screening, how important screening is, and early identification. And much like with hypertension, where you don't know somebody has high blood pressure unless you check somebody's blood pressure, you don't necessarily know if somebody has depression, anxiety, or a substance use disorder unless we ask the right questions, sort of a mental health vitals, if you will. These chronic care models, again, using that analogy, also involve preventative care, specialized support for primary care providers who treat a tremendous amount of depression, anxiety, and substance use concerns in primary care, and they do an incredible job frequently with very few resources. Usually depression and anxiety are two of the top 8 conditions addressed in any primary care clinic. But also those chronic care models also utilize tracking tools, and as well as quantitatively measuring progress. And there's some healthcare systems that are incorporating elements of this work, but it's certainly not uniform.
Mm-hmm. Yeah, on that screening topic, what's been challenging about implementing that, or any thoughts on taking place more?
Yeah, it's a huge challenge, and I think that I've had the opportunity to work in a number of systems in fee-for-service and capitated PM worlds, and the challenges are unfortunately many, and I think there's really a lot of great intent and desire to ask those questions and great alignment about how to do that. One, the financial incentives aren't always aligned. The ability to pay for those, reimbursement around those kind of services. SBIRT helps. Screening and brief intervention referral to treatment models help, and there's some reimbursements for those, although they're very modest. And so getting that financial alignment, plus, we as an industry really overburden our primary care teams. They really are doing an amazing job, frequently with very, very little resources as an industry as a whole. And so I think that those, of course, they've got a number of other metrics and screenings and that they need to do as well that are equally important. But I think those areas that have a behavioral health consultant model for integrated care tend to do better in general because you've got that embedded behavioral health clinician right there in the moment to help support for when there may be an acute need that arises in primary care. I think understandably, primary care teams are reluctant to ask questions unless they have a resource they can refer somebody to in an acute setting, and rather than just sending somebody to an emergency room or an urgent care setting. And I think an example of that I just heard, I've heard numerous examples, but one of the most recent ones was somebody who hadn't been seen in a while, came in for a relatively benign medical concern, and the primary care team recognized that they had not been screened for depression or substance use disorder in the prior year. So we're asked the PHQ-2, which was positive, which rolled into the 9, PHQ-9, which was positive for item 9, which is that they were having thoughts about harming themselves. And the clinician was able to pull in a behavioral health clinician in that moment in the exam room in a low stigmatizing environment where the patient didn't have to go to a specialty clinic, didn't have to go to urgent care or an emergency room, and safety plan was done, including means reduction by that behavioral health clinician, and the patient did not need to go to emergency room, did not need to be hospitalized, and an appropriate follow-up was able to be scheduled. That's really how it should work from the patient's perspective, to be heard, cared for. And if that clinic hadn't been asking the right questions, those concerns may never have been discovered and addressed in that moment. And so sensibly a life was saved there, literally a life-saving intervention just by asking a couple of questions. But the barriers really are around our overburdened primary care teams throughout our industry, and really a lack of support within the primary care team to ask those questions. So having a really integrated behavioral health model, particularly a behavioral health consultant model, where they can intervene in those moments can be really critical to help promote those the primary care teams to be able to ask those screening questions and feel like they've got the support to be able to address those concerns when they come up.
Mm-hmm. Wow, what a story! And that model wasn't, I think that was invented somewhere in your neck of the woods too, right? Washington.
It was. There's a couple different places where it sort of originated and taken roots, but the Puget Sound area is one of them. Yes.
Awesome, interesting. Well, telehealth has certainly been a huge hot topic lately. Would love to hear your thoughts on how you see COVID-19 impacting behavioral health and telehealth in particular.
Yeah. So, I mean, we've seen more movement and progress in telehealth in the last, in the first 4 weeks of COVID than we did in the prior 4 years. But it's been really gratifying to see the adoption go up and to see, as I have shared in some social media, I was working at one organization and we were rolling out video visits, and there was a clinician that said they, were concerned about doing video visits because, the patient coming in to see them was an assessment of their motivation to change. And, I think that we as an industry need to change how we think about some of those things and how we think and how we can reduce barriers to access to care. And certainly telehealth. And when I think about telehealth, I think about a face-to-face intervention, interaction, much like we're having right now. So simply, in essence, replicating what would happen in a psychiatrist or a clinician's office, but just using a video modality. So I think that the COVID-19 has certainly helped to bring along some of those mid and late adopters and folks that had initially concerns about it. And I think the experience has allayed a lot of those concerns and realized that people can be effective. This is an effective modality. I think the telephone is probably the most innovative technology that we could use in many situations, and there's a lot of community health centers that are using it very effectively. Just simple telephone calls for some of their clients and individuals that don't have access to some of these technologies. I think that there's going to be more demand for more services. We know that as a result of COVID-19. We're already starting to see some of the signs of that with the increased calls to crisis lines and increased requests for services. And so I think in my mind, that just creates an even greater sense of urgency for how do we build out that continuum. And I think telehealth is, a component of that. But it's also just kind of the one element. So again, I think what telehealth and digital therapeutics and things are able to do is to get people to the right level of care as expediently as possible. Again, thinking back to that analogy of the continuum of care, like diabetes or hypertension, that have very robust continuums of care and very well established clinical pathways about where somebody goes along that continuum based upon their lab values or their blood pressure. And we traditionally as an industry, regardless of where somebody falls along that continuum, they sort of get on that one escalator that goes to a face-to-face visit. And that escalator is getting very, very crowded. And not everybody needs that level of intervention. I think, don't get me wrong, there will always be a place for face-to-face and in-person intervention. That's we will continue to need to have that need. But there are people with clinical presentations that can be more effectively addressed, arguably, and certainly more expediently addressed with the other kinds of interventions like digital therapeutics and cognitive behavioral therapy modules and things like that. Again, I keep referring back to diabetes or hypertension as the analogy, but somebody with a relatively low A1C doesn't go always to see the endocrinologist. There are other ways and mechanisms for that individual to be cared for other than just seeing the specialist, but yet the equivalent of that in behavioral health happens all the time. And so I think telehealth and digital therapeutics are really critical components about how do we build out that continuum so we can A, get people to the right level of care, and B, do it as quickly and as expediently as possible.
Mm-hmm. Yeah, couldn't agree more. And I'm sure a lot of our audience feels the same way, given the topic of the conference and just what's going on in the world. But just to be a little bit of a devil's advocate potentially, on social media, you being the social media maven that you are, I've seen you post. Telehealth isn't always the remedy either. So could you elaborate a little bit on that?
Yeah, I think there's been a lot of conversation on telehealth, and when I think about telehealth, I think it's really important to define what we're talking about. And as I mentioned earlier, when I think about telehealth specifically, I'm thinking about a video interface that essentially replicates what would otherwise happen in a psychiatrist or a therapist, a clinician's office. And so, and there is incredible relevancy and value in that in and of itself, and I don't want to minimize that in any way. I think telehealth is a really valuable tool in helping to minimize some of the inherent barriers and social inequities within healthcare. I think about hourly workers who have to travel, take time off from work and travel. I know in the Seattle area, at least, and, pre-COVID, it could take you sometimes an hour and 20 minutes to go 8 miles. So, to have to take time off from work to go to a clinician's office when that could be done via video, I think is really critical and a really important and valuable step in helping to minimize some of those social inequities. That being said, telehealth, unlike other specialties, let's say take primary care, for example. Primary care will take a 15 or 20 minute visit and cut it up into 2 or 3 video visits because it's video visits for primary care tend to, and I'm generalizing here, but tend to address one singular issue. So they can truncate. So it's a way for other specialties to expand their capacity to be able to see more patients. But in behavioral health, what we deal with primarily is time. Even the billable service is based upon time on an outpatient basis. Mm-hmm. And so it really doesn't expand our capacity. It arguably makes better use of that capacity, and that no-show rates for video visits tend to be a little bit lower than in-person visits. So it makes better utilization of that capacity, but doesn't actually expand our ability to see more patients, again, it does help to spread that capacity into areas where there may not be clinicians in more rural areas and things like that. So it's absolutely an important thing for us to continue to do, but it doesn't help us to see this growing, increasing number of individuals in our communities who need our care and need our services.
Mm-hmm. Yeah, absolutely.
And
Interesting.
I think that's really where some of the other tools like digital therapeutics and CCBTs, computerized cognitive behavioral therapies, can come into play for those patients who may be subacute or mild into the moderate end of the continuum, who don't necessarily, again, using the chronic care analogy, whose behavioral health A1C equivalent isn't high enough to merit necessarily going and seeing a psychiatrist or a therapist. And it comes back to how do we have those tools available? How do we build out that continuum? How do we advocate for the payment methodologies to support those? And then how do we support our primary care partners in being able to leverage and utilize those tools and support them in being able to hold those patients in primary care, which many settings are already doing, but without the necessary resources.
Yeah, wow, interesting. Payment models, and that's a good segue into my next question is, what do you see as some of the biggest barriers to the adoption of more telebehavioral health or digital tools?
Yeah, there's a couple. And so, certainly the payment models is the biggest barrier in the fee-for-service world for sure. Particularly for digital therapeutics, it's very, very challenging. And so I think that CMS and other payers certainly need to make permanent some of the changes, emergency changes that have happened to help accelerate telehealth and even expand those further. We also need payment methodologies that support the utilization of computerized cognitive behavioral therapy and other therapy alternatives. Because in the long run, while our total spend on healthcare and behavioral health rather will go up, if we're able to effectively utilize these tools, the payer groups that will hopefully see their episode of care costs go down. And we're getting people care more expediently, as quickly as possible. And we've all heard stories, I certainly have, around people who have to call sometimes 20 to 25 to 30 clinicians in their private practice network to try to find somebody who will see them. And there's lots of research showing that even though those patients who have more acute needs have an even harder time getting access in the private practice community, which again is where the majority of people across the country are seen for outpatient care. So, and then finally, we need to change the public narrative about what mental health care looks like to receive. I think that we have in our culture so steeped an idea about what it looks like to receive mental health care, because a bearded guy in Vienna 100 years ago said that's the way it should be. We kind of have that in our mindset. And as an example, one of my favorite stories is we had somebody once call for requesting services, and they wanted to talk to somebody about what they were experiencing. And really turned out they wanted therapy, but they were insistent that they wanted to see a psychiatrist. And our clinician that was triaging the call was trying to explain to them that's not really what psychiatrists do these days, and was trying to provide some education. But they were just adamant that they needed to see psychiatrists because Tony Soprano saw a psychiatrist. And so I think we need to do what we can collectively to change the narrative about what does it look like to receive mental health care. It's not just seeing a psychiatrist. It's not just seeing a therapist necessarily face-to-face. That all these other tools are equally effective for those particular conditions. Again, thinking about matching people where they fall along the continuum of need with the right interventions. And so I think we need to do, as an industry, just a lot of work around how do we change that narrative and the conversation about and perception about what it looks like to receive mental health care. I think we've done a pretty good job. We have certainly more work to be done to reduce stigma. Certainly a lot of work in that area still. But I think the next wave of that, next phase, if you will, is really about what does it look like to receive care potentially. And it doesn't also always have to be a face-to-face visit. Again, I think there'll always be a place for that, but it doesn't have to be that.
Mm-hmm. Right. That's such excellent points. Um, uh, and we've got a few minutes left, and I want to highlight how exciting it is of a time that some of these things are starting to finally evolve, um, and the marketing of these solutions is just starting to emerge so that people can know the different options that are available. But um, my last question is, what concerns you the most as we look into the future of behavioral health care?
Yeah, there are two things that concern me the most. And the first, I sort of alluded to it earlier, is that there already is research out there emerging. It's hard to find good data, but there's literature, some stuff out there that shows that upwards of 50 to 60% of private practice clinicians no longer accept insurance at all. And so this just makes a tighter and tighter, narrower pool for those who have to rely upon their healthcare benefits to access care and aren't able to pay out of pocket. So one of the concerns I have is that as the increase in demand happens with COVID-19, that this will cause more private practice clinicians to opt out of the insurance market entirely. And this is not meant to be pejorative at all about my private practitioner friends and colleagues. It's just sheer market forces. It makes perfectly good, reasonable sense. But I'm concerned about that because those folks that need to tap into their health benefits will just find themselves having a harder and harder time finding access, and it just brings up some significant social equity issues in my mind.
Mm-hmm.
The second thing that I have concerns about and also have hope for is that really in our industry, we have very, very few measurements of quality. We really don't have a lot of quality-based measurements of care. And, we have PHQ-9s, but those are still very subjective. The vast majority of clinicians in the private practice market don't use PHQ-9s or patient satisfaction even. And so we really don't know what's happening. We get, insurance industries can get claims and CPT codes, but that's not really quality data. And so I think that what gives me hope is that a lot of the large payer groups are starting to pay attention to this. And as we think about more things moving towards value-based payment contracts and movements, that there's ongoing and increasing conversation about these large purchaser groups wanting to pay for value-based outcomes. They want to know what percentage of their employee and covered lives are being screened for depression, for substance use disorders, what percentage of patients are having safety plans done who have been identified at high risk for suicide. So we're moving in that direction, but we're really still in the very, very genesis of all that. So a concern, but also some hope.
Mm-hmm. Yeah, that is very hopeful to see all these stakeholders that you had mentioned giving that kind of attention to the issue. So I would agree with that. And I wish I could have just a few more hours with you, as I'm sure I'll agree. But this was really excellent. Thank you so much, Roger. Everyone's so excited that we could have Roger Dowdy, Vice President of Mental Health Strategy from Providence St. Joseph Health System with us today. And please continue to follow on for the rest of the show. Thanks a lot, Roger.
Great, thank you.